Welcome to another episode, Smiles in the Air. I'm Celso da Costa, and today with me I have Daniel Morgan, a master in chiropractic sports, chiropractic even.
Yeah. So I did my master's in chiropractic as my undergraduate, and then I've done a master's in sports medicine, and now I'm just completing a master's in diagnostic ultrasound. So a couple of educational backgrounds there.
Yeah, and I just had the pleasure to have a treatment with you.
Yeah. First time with us, but yeah, it was it's your third session of Shockwave, isn't it? So
It is the third session.
yeah.
So we recorded an episode where we got Philippe Gilmer because he have done a treatment, and then we were talking about it, and this is the third time.
Yep.
So for the listeners, I was suffering a little bit from my right foot, on the bottom of my right foot, and it made me stop running for now 4 months. But I think we will be able to start running. So you can explain a little bit what we have done.
Yeah. So I think today was really useful. I think for yourself as well, knowing what to do going forward. But we've basically done a diagnostic ultrasound scan. I've brought my scanner over, and I think the thing that we can take away from today is the location of your pathology.
Yeah.
We can identify now that your pathology isn't exactly at the calcaneus or at the base of the calcaneus. So we know that it's probably around about 2 centimeters away from the site of insertion. So that classes as what we would call a non-insertional plantar fasciopathy. So when we focused the treatment today, we were able to get very specifically onto that site and then work some of the myofascial components. So again, for the listeners, that the myofascial components is like the rest of the fascia or the muscles underneath. So yeah, we've done that, and we a couple of impulses through there, and immediately you get up and you feel lighter. And interestingly, the research is saying that that's one of the predictive factors for a positive outcome amongst treatment. So you're in that favourable category, really, in the sense that you've got up off the bench, feel so much better immediately.
Yeah.
So now it's about trying to going forward with you over the next couple of weeks, couple of months. Obviously, carry on with the shockwave, carry on with your rehab, the strengthening, but it's going to be vital to manage your load in terms of return to running. So we don't want you to spike that too much. We don't want you just to go sprinting and try to go back up into your half marathons. We want to try and graduate that return. So otherwise you'll start to get your symptoms again.
Yeah.
So as good as what we've done, it's just important what we do going forward as well.
And it was so funny because you have done the scan, so finally I understood what was happening and not just a theory that normally we are explained. And you showed the difference between my right and the left foot.
Yeah. It's a massive educational tool, the scanning. I think that from my standpoint, it reaffirms to me what I'm doing. So that I am treating the right pathology, I'm treating the right thing. But also from you as a patient, you can actually understand and physically see it. So the fact that you can visually understand the change in the tendon or the fascia or whatever structure we're dealing with, for you to understand that and to see it, I think that it's just a reinforcement tool as well.
Yeah.
And it can be a positive and a negative from some standpoint. It depends on the patient, but some people can look at it and go, oh, that means that it's really bad. It's like, well, no, it just means that we've identified that there's a problem and that we now know what to do. So it depends on the viewpoint. But for me, I put a positive spin on it, and we say, well, now that we've seen this, we can actually know that this is the start of your journey, and this is how we can build off of that platform, essentially. But yeah, it's really important. I think I like that. I like combining it and having the ability to do the shockwave and the scan in one session is just beautiful. It's really nice.
For me, it was positive. It was positive. You showed me the problem. Not only that, you have done some movement, so I got more conscious what I need to do and I cannot do.
Yeah.
So to say. Yeah. And then you just treated in that region. So it was really localized, super detailed.
Yeah.
And your movements, like I need to say, I'm a clinician also. So but when we are in the mouth of the patient, in my case, we need to be precise.
Yeah.
And there it was exactly the same thing.
Yeah, I think that precision is important, and it's knowing what we're treating and knowing why we're treating it. And I think it's what and why is the questions that we really need to be answering or asking. If we can understand what we're treating and why we're treating it and what the goals of the treatment are, then we're going to get better outcomes immediately. And I think that sometimes we forget the why. If we don't understand the why and why are we doing this, then we're not really understanding what we're trying to achieve. But I think you're right. The specificity is so important with structure, because there's no point in, ultimately with the shockwave, it doesn't impact the tissue that we're not working in. Like if we aim the shockwave and the radial pulse waves, if we aim that into a different tissue where the pathology isn't, it's not going to impact on your outcomes.
Yeah.
So specificity and being really specific with the target and the treatment area is really important, I think. And I suppose it's going to be, it's obviously got to be the same for you. There's no point working on the wrong molar.
It's
is
true.
It?
True.
There's no point trying to, if you've got a cavity and trying to fill the other teeth, it's pointless. So specific is really important when it comes to shockwave. I personally would say that's the way that I would look at it. Obviously, you then look at the myofascial components, which is less specific because that's just looking at the connective tissue. So that's looking at other potential contributing factors. So with you, we were looking at your feet. You used to play football.
Yeah.
Still do? Still play?
Not anymore.
No. I know. Past life for me as well.
Getting too old.
Yeah, I know that feeling. So with you used to play football. So countless times there's normally ankle injuries within football. So you've got quite hypermobile feet. So whether or not that's having a contributing factor to the development of the plantar fascia or the plantar fascia issue, that's something that we also want to take into consideration. So as well as working that site of pathology, we also need to look at the contributing factors. Is the calf tight? Is that playing a role? So we can also then work up into those. And, from a dentistry standpoint, I'd imagine you say, well, okay, you've got a fill-in, but why? You need a fill-in. So why do you need a fill-in? Look at your diet, look at your nutrition. Yeah. So for us, it's a similar sort of thing. You've got plantar fasciopathy, but why have you got plantar fasciopathy? And we also need to address that. So it's, two worlds, but sort of similar thought processes.
I like the way, because you saw me as a whole, actually. And you asked some questions, and you do this in your daily basis, because you are treating rugby players also. That's what I understood.
Yeah. So I work in professional rugby in Wales. So I work with Scarlets Rugby as well as in clinical practice. So I work there once a week. So we go in and we're looking after the players from their neck, their spines. Introduced Shockwave over the last 2 seasons as well, which is really, really positive. And always around pre-season, we find that there's a couple of Achilles issues and niggles. It's because there's been a spike in the running load, and if there's kind of an association with changing running capacities, as well as like alcohol consumption and kind of antibiotic use. These things are actually identified as precursors for development of Achilles tendinopathy. So main one within rugby in the pre-season is going to be the massive change in the load. So we work that, and the Shockwave has been introduced. But from my standpoint, I work a lot with the neck and identifying neck function a lot with the front row, with the propping and the scrummaging skills. So we try to resolve those and try and maintain that. So rugby has been a big part of my practice over the last kind of 5 years. I've been involved in professional rugby. It's been an amazing experience to work with those. And watching the World Cup over the last couple of weeks. I'm a bit in mourning from Saturday, but it's been good though. I've loved working in rugby. The boys, the development, the kind of environment is really, really nice. Really nice place.
You do a lot of prevention with them, to avoid injuries, and so what kind of prevention are you?
So interestingly, as a side portion to kind of practical treatment of the rugby players, I'm involved with a prevention study with concussion. So we're actually doing a little bit of a study with Gloucester Rugby, Saracens Rugby, and Coventry Rugby we've involved with, and is Harlequins as well. So we've done a couple of clubs, and we've looked at some pre-assessments and looking at ultrasound actually is one of the factors, where we're looking at the neck cross-sectional area, neck strength, and it's a big project evolved probably over the next 3 seasons, I think.
Okay.
So prevention work is with concussion, what we're trying to do is, if we can identify potential causation, then we can then look at changing that into what can we do to prevent the causations. But yeah, and there's some evidence now that we're looking at in terms of exercise prehab, that sort of thing, that we can include into our treatment managements to prevent the reoccurrence of your injuries. So maintaining your calf strength, for example, and the mobility to prevent sort of further kind of onset of pain, really. Again, and whether or not neck function is associated with concussion is one of those things that's up for debate amongst the literature at the minute. So we're looking at that, and so prevention is a massive part of what we're looking into over the next couple of years, whether that's concussion or any other musculoskeletal injury. But prevention is key, really. I think if you can stop players developing injuries, then there's less time off, more likelihood of success. There's been multiple studies that have been done on that in football specifically, just because typically football is more of an expensive game. So they've actually quantified the amount of time that a player being off can cost a club. And there's been a 13-year study over, I think it was probably about a decade ago now, but Ekstrand did a study looking at recovery times with hamstring injuries. And there's also been a study looking at the success of players, availability. So if the best players are available, the more likelihood of team success, which sounds really obvious. But there's been a study to say that, and that was done over, I think, a 13-year study, something like that.
Wow.
And it was with a lot of UEFA clubs, so in the Champions League, Bundesliga. So the big studies, and again, like it highlights the importance of prevention of injury in what we're looking at. True. And it's like, again, in dentistry, I suppose, is the prevention of...
Is the prevention. Yeah. What we apply here with guided biofilm therapy is exactly the prevention of disease. Yeah. I just got treated with the Doll class. Yeah. Do you use the Doll class only for treatment or also in the prevention phase?
So, I think that you can use it a lot of the time just using a flush through for muscular elements. Like, majority of it in clinical practice is for treatment, just because... most of the time people will come to us with a problem. So, it's very rare do we have a lot of... having said that, we do have a bit of preventional treatment stuff coming in. So back pain is the majority of what we would see. But I do use it within running through the hamstring, certainly. And, in the Bundesliga in Germany, they're using it at half time, basically, trying to get a flush through the muscles. So obviously it's a different applicator and different settings. But it can certainly be used for, again, over the season, if we're starting to see, with the rugby boys, if we're starting to see a little bit of a niggle within their Achilles, then we try and say, well, we'll nip it in the bud and stop it before it really develops into a problem, so we can use it then. And that I quite like. I really like doing that because it kind of stops it in its tracks then. Interestingly, last week we had a runner, she won't mind me telling you this, I won't mention her name. We had a runner who was running the Cardiff half, and it was a posterior tibial tendon issue. And I sat her down on the edge of the bench, and I was kind of quite serious. And I was like we have to address the fact that you may not be able to run this. You're in quite a bit of pain. And she's like, I know, but if you can just get me to the starting line, then whether or not I finish is another issue. So it's like, look, okay, we'll try our best. And what we did, we combined cryotherapy. So we had a compression boot, basically, which was pumping ice cold water around it. And then we did that 3 times, and we did 2 shockwave sessions on the muscle belly and coming around into the medial malleolus around the tendon. And on the Monday morning, I got into work, and there was 2 boxes of chocolates and a card to say thank you. Because she completed the half marathon, but a week earlier, that was never going to be the case. Yeah. So we managed to kind of just nip that to a point where it didn't really develop into anything. So that was a nice kind of...
That's a proud moment.
Really nice moment. Yeah. And it's not an elite level at all, but it's even those... It's a big goal for someone. It was something that she really wanted to do. So for us to be able to get her there, you take an element of pride from that. And I think that I've played a role with trying to get a few of the players, and made them fit for selection for squads, and whether or not that's Lions, British and Irish Lions, or whether or not it's not me specifically, but the team of us that are involved with that. And playing a little role in that is really rewarding. But at that standpoint where you've even got amateur runners just able to complete a half marathon, that's just as rewarding for me.
Because I understand you're a runner. I do a lot of sports.
Yeah.
Right.
Yeah.
So, and every night I will go to that gym, even if I'm in good shape or not.
Yeah.
Because it's a battle with myself.
Oh, yeah.
You know? And it's like, oh, this is tiring. I can give up. And then I have a dear voice. No, you cannot give up. Go on.
Yeah.
And if we have people like you helping us to achieve these goals, I think it's great. And you must feel amazing also.
Yeah, it's a two-way street though, isn't it? Like, you've got to be willing to help yourself as well.
Yeah.
I think that's a massive factor. But yeah, if we can, sometimes people just need that little bit of encouragement as well. And I think that we use a little bit of a saying where if you're ready to do something, it's like you've got your shoes on, you're ready to go for that run, but you're just not quite out the door. And sometimes you just need that little push.
Yeah.
So that's kind of what I do. I think a lot of people always thank us as practitioners, and they say, oh, thank you for this and thank you for that. But actually, a lot of the time, the patients do well themselves. If it wasn't for them doing their bit, the recovery may take twice as long. So we can't take all of the credit for what achieves, or what the patient has achieved. But it helps, and that's the thing, is that if we can help them along,
you're
the
part
way,
of it.
You're part of that journey. And on the flip side of that is that we had a patient that was diagnosed with fat pad impingement a couple of weeks ago, and we had to refer out. And they phoned me on Friday to say, oh, look, it doesn't look like I'm going to be able to run my race. So you take the wins with the losses, but you feel every bit of it with them, like the highs, the lows. Like I was gutted on the phone for him when he said, like, I'm not going to be able to travel. And it was a Ironman or a triathlon abroad. And I was just like, and you feel it, and you really do. And you feel like you've not let them down, but you feel as though you haven't done them justice. But you take that, like I certainly do as a practitioner, I take that as like, oh, that's a personal defeat. But you can't win them all, can you? But you try your best and you do everything you can for them. So yeah, it's I think that's just me as a practitioner as well, though. You want to help and you want to do everything you can. I suppose it's the same in anything. But you are right. It is always again. It's not the elite levels. It's always, it should be you against you. You never compare. You should never really compare against other people or what he's lifting in the gym or how fast he's running. As long as it's a personal and self-improvement, that's what we're really after.
Yeah, everyone has their goal, so why not to help them?
Yeah, it's all relative. It's all relative, as whether or not it's to be fit for a Lions tour or whether or not it's to run a 5K.
Yeah,
everyone has their goals, and we've got to just get them there and try and get them there as fast as we can, and as efficiently as we can and as safely as we can. And that's the other thing.
They told me a story about you.
Oh, go on.
So you were doing dollar class treatments before and after a running event.
Oh, yeah.
And there was a person coming to you and saying, listen, I'm a yoga teacher, but I cannot do some of my movements. And then you have done a couple of exercises with this person and said, listen up, you have a problem with your rib. So you need to fix that.
Yeah. Yeah, that was in Run Fest in Winchester. And it's really interesting. That case, she was very flexible, and she had a little bit of I was upper thoracic pain on the right side, and I think we were assessing it, and I was kind of like, look, the rib was very proud. It's really strange when you palpate, you can just feel that the rib is quite proud underneath the scapula, and it can change the way that your shoulder functions because of the scapular thoracic rhythm. So having a little bit of mobility and mobilizations in and around there can really help. And we also do a before and after kind of shot of that patient, I think. And I think Alex may have caught it, where I'd shockwave down the lumbar spine as it's just a part of the myofascial components. We treated a little bit of trigger points, and then we did the larger applicator working through, coming into the low back and into the glutes. And she was so much easier into forward flexion. She could reach that a little bit further. And it's just really nice that, again, you can see those instant results with what we do. I think on that case, I'm pretty sure we combined it a little bit with chiropractic care. So I think that I did do a little thoracic manipulation and a rib manipulation, and that immediately improved her rotational plane. But yeah, that was a good case. That one. It's quite nice to see those instant changes.
You are not only helping people to achieve their goals, but you are improving also their skills in their career.
Well, yeah, yeah, and that comes actually into dentistry as well, though, massively. When posture is a big component of why we see a few dentists in clinical practice, and it's that rounded posture if we're working over patients typically. And it's key then, how do we adapt your postures to be able to keep yourself into a safe sort of sitting positions, and do you lean from your hip rather than leaning through your thoracics, and how do we change that in little ways, and keeping your core nice and strong and shoulders back and little things like that, little tips, and how do we strengthen that, how do we get that going. But yeah, that totally comes into your profession and into dentistry, because prevention, as you said, how do we prevent those postures from occurring, and how do we, bad habits typically, how do we prevent that? And it's keeping strong as well, and that's really important.
Yeah, that was a nice bridge, because I was preparing a question like,
yeah.
how can you help?
That's in read your mind.
The dental professional. So you were reading my mind.
Yeah, ahead of the game. No, yeah, it's like for us, I think the thoracic tightness and tension with dentists is a big thing, and it's often due to the way that they're working constantly over patients, and whether or not they're rotating, and are they leaning forward, and it depends on the setup and how we can adapt that for each individual person. Like, your setup, if I was doing it, it's completely different.
People. Yeah,
exactly. So it's like an occupational health in some ways, where you go, well, as if you're a desk worker, how do we, arrange your desk? Yeah. It's the same sort of thing as how do we arrange your chair setup.
I think that's it, because it depends of your height already, the space that you will cover also on the practice. I think the workflow, like having your tools quite just reach off a arm length, it will be really, really important to have the patient, the head of the patient, close to you and nearby your belly, so you keep a straight posture. Shoulders, elbows, distance from the elbow from the rib cage. I learned all of this in the hard way. My first year was so bad. I was feeling pain on my back, my shoulders, my neck. The end of the first year of that I got as experience, fresh off the college, and then what I start doing, seeing the physiotherapists regularly, exercising, way more,
massive.
Wearing loops,
and
changing also my posture around the patient.
Yeah, so I think exercising is a massive part of that. Incentive with you guys is kind of making sure that we have a really good pull strength.
Yeah, exactly.
So your back is nice and strong, so you can. Well, we used to think that it would be a lot of like stretching, so you'd stretch this anterior chain and stretch your pecs out, and it's like, okay, they might be tight, but it's normally because there's an imbalance from the front to the back. So if your back isn't as strong, then your front is overpowering it, so it's pulling you forward.
Yeah.
So keeping back strength, so all of that pull base, the lat pull downs, bent over rows, trying to get everything nice and stable, setting those shoulder blades in. It's a really important one. Like we had a tutor in university, so it was drilled into us within. You don't want to see a chiropractor with a bad back, do you? So it's like, it was drilled into us from early days. Dr. Annabelle Kia, she was a massive one for this. And she was like, shoulders back, hip hinge, like make sure we're getting all of this right. And it stuck with me quite a lot.
But she's right.
Totally.
If you're a health professional, you need to self-help.
Oh, yeah.
So it's the same thing. And when I'm teaching other clinicians how to use it, that's the first thing that I do. Like, good posture.
Yeah.
I was telling you, keep 4 fingers from your rib cage or from your elbow. I'm really specific. You need to have a 90 degrees angle, and your wrists need to be straight. Don't do this, don't do that. Keep it straight.
Yeah, and that comes into, again, the development of kind of your tennis elbows and those sort of things, and RSI, repetitive strain injuries. But yeah, you're right, and I think that we can do a lot to look after ourselves, and that is the prevention element of it, and that is for most part, education.
Yeah.
I think that we need to, as practitioners, educate the patient to be able to identify what's wrong. It's the hardest question in the world to answer as a practitioner is like, why has this happened? Because the truth is, we'd have to follow you around for about a week to say, well, it could be this, it could be this. There's
True,
multiple facets to the reasons that things could develop. But with tendons, it's normally an overuse thing. There is a development of plantar fascia, which can be identified in a sedentary patient, which is typically not an overuse thing. But we'd have to identify to truly identify, like with this sense of if you develop the cavity.
Yeah.
I need a dietary kind of
Log.
diet log, and I need to know what you're eating, when you're eating it, what amount of sugary foods you're taking in. Coffee, for example, acidic. I love coffee, but it's an acidic nature. I only recently found out from my visit to the dentist that the tea, like your English breakfast tea or your herbal teas, that contains fluoride, I think, which is actually quite protective for the enamel. So teas are good.
Exactly.
Who knew? I didn't know that. So I'd learned that this week, and it's just like little things where you can make habitual changes and habit changes, which can play a massive role into, preventing the development of conditions.
Yeah. I had a professor. It goes a little bit back, like your professor in the university. So my professor in the university, Professor Eduard Marx, he always told us, the day that you get in your car after a hard working day, and you see that you are leaning for one side or the other one, it's because you have bad ergonomics at work.
Yeah, that makes sense.
So, and he said, like, if you do this, start correcting your ergonomics.
I think that's a very valid point. You catch yourself doing it sometimes, don't you? We have a favorite side of the bench. I don't know if you have a favorite side of the chair.
Yeah, I do.
So it's like I have a favorite side of the bench where I'm quite comfortable and I'd lean to one side, and so that is something you really want to get out of. And you try to. We were always encouraged, certainly, like, to get used to using both hands and try to, and certainly from a scanning standpoint, I wanted the Dr. Denton, Roger Denton, who trained me on the ultrasound. He was really hot on, you need to know how to hold the probe, you need to know where to sit. Again, looking after yourself and your ergonomics. And that was a big thing for me to learn and have to kind of get used to. And particularly with when I was in university, so when we were learning, we had different height benches. I'm not the tallest person in the world, so I really needed like a low bench. But then, thankfully, in practice now, we've got hydraulics, so I can adapt it quite specifically, which does help. But yeah, it needs to be right for you. If it's not, then you're just putting yourself at risk. And ultimately, if you're at risk, you can't go to work if you've got a bad back, and if you can't go to work, then you can't earn money, and if you don't earn money, and you're also letting patients down. So it's this knock-on effect to really looking after yourself in workplace is quite important.
Yeah, the first guest that we got in our podcast, it was Karine, a Canadian dental hygienist, and she was telling her story on the other building, how she was suffering with carpal tunnel. For 9 months, she couldn't work, always physiotherapy, the tapes and everything, and she couldn't do anything. And then she changed it for the GBT. As GBT is less manual work, so less fine movements. So, and now she's working again full time.
Yeah, it's amazing. Little changes can make huge differences. And again, it's that identifying the major irritating factors. So if you know that your workload or how you're doing something is irritating it, and sometimes you're left with no other issue but to kind of adapt. You have to adapt and change the way that you would work things. Particularly if you're looking at carpal tunnel, you can go down extreme routes then of having surgical interventions, actually cutting the carpal tunnel, and then that leads to more time off work. And you've got all of these different contributing factors that need to be addressed. But the worst case scenario with those sort of things, and particularly in dentistry, if you're losing your dexterity and the sense of sensation within those fingers, and typically is those three fingers which you would normally be working with, it is going to be difficult to work, isn't it? So that's a good case actually, where we have shockwaved a little bit of carpal tunnel. Results are quite mixed with it, but it's still, it's a potential that you can do that. But again, it is that two-way street. Unless we change nothing as a patient, then it's not gonna, it may not change. So you need to identify that. It's quite a good case to.
Yeah, and I learned with Philip Gilmer also that we have 3 fingers for the fine movements.
Yep.
And these 2 fingers, they are the strength fingers.
Yeah.
Because I at the gym, I was pulling too much. Maybe that's what you say. I don't know. And I will start feeling due to these two fingers. And so even as a dental clinician, we need to be careful also with this.
Yeah, I think.
Notion.
Yeah, definitely. You're looking at that kind of golfer's elbow, as it were, then coming into that flexor origin, and it's quite. What we would do there is, with yourself, we kind of work down with the myofascial components right up into the forearm, and you can do a little bit of actual not carpal, you do ulnar gliding, so you can try to get a little bit of nerve floss into that ulnar nerve, and that helps quite a bit to just get some gliding and things like that.
Okay.
So there's little ways that you can manage that. Sometimes you can actually get a subluxating ulnar. So the ulnar nerve will sublux under here.
True, here, right?
Yeah, it clicks and pops, and you can get like tingling then in these 2 fingers. Our physio that works in the clinic with us, she's actually got that, and when she's gone to the NHS, it's been like, what can we do about it? And all they've offered is a stabilization. So they would go in and then basically stabilize the sheath or the ligament that's not working.
Yeah.
So it's a surgery to prevent it, and again, that's not ideal, is it? When you've got to go into work and you can't because you've had surgery on your elbow.
Yeah.
But yeah, these all of your hands. I mean, certainly with dentistry, your hands work is you got to look after those. They're your tools, and
you need, because you are always with these 3 fingers for the details, but you are always also using this for the support.
Okay.
So you use the full hand at the end.
So interestingly, when we were talking about that as a support, when I was in university doing the chiropractic degree, we were forced, or not forced, we were told to maintain a what we would class as a chiropractic arch, which is not a flat hand, it would be a little claw, basically. Okay. So when we were training in first year, second year, they made us do 10 press-ups in
the claw position?
Yeah.
Okay.
So that we could support our body weight. And it's to strengthen your hand.
Well, that's cool.
Which is quite interesting.
We'll try that.
Yeah, let's give it a go later. I don't know if I can do 10 press-ups anymore. Yeah, no, but we can. So we were told to maintain that arch. And actually, we had to do 10 press-ups every practical session that we did to make sure that we could maintain that support. And that shouldn't go anywhere then. And it's just to make sure that we have a nice contact, because when we do any adjustments or manipulations, we use the hypothenar and the thenar eminence. Okay. So it would be, the contact would be there, or it would be there, and that would be basically into the spine then. So that's how we.
That's super interesting.
Yeah. So like, if you use that as your support, we use that as our support. So this isn't really doing anything. So it's fingertips and palms.
Okay, that's a good tip already. Yeah. So everyone gonna start doing their 10 press-ups.
10 press-ups to the claw.
Before starting the day. Daniel, it's really cool. Like, I could spend hours with you. Any final thoughts or tips for dental clinicians that want to prevent musculoskeletal diseases?
Yeah, certainly. I think for me, it's about maintaining your strength and postures. I think that's going to be a big thing in your clinical practice. It's acknowledging whether or not you're rounding, whether or not your kind of shoulders are coming forward, whether you're quite tight. And I think that what we want to do is try and strengthen your back muscles quite a bit and keep that core nice and strong. It's really, really important. And one thing that I kind of drive is a little bit of a hip hinge. So rather than kind of slouching, it's leaning from
by the hip.
Yeah. So hips will come forward rather than shoulders. I think that's quite an important one. Again, it's making sure that ergonomics are set for you. Mm-hmm. I think that's really key. It's just like any other job, whether or not it's a desk job, you want it to try and be as specific to you as possible. But yeah, strength is going to be key. You again look after yourself, whether or not that is chiropractic care, physiotherapy. Just trying to keep yourself nice and active and strengthen that back. You can do some mobility. I think mobility is really key as well, because you can stretch out that thoracic spine, which is going to be a big driver for symptoms in dentistry. So yeah, and simple things for your neck is really quite a good one, because neck pain, upper thoracics. So we would look at doing simple chin tuck exercises where you can lay onto your back, tuck your chin, and then lift your head up off the floor. So they are really nice ways to strengthen those deep neck flexors. And then you can also do it onto a quadruped position, so on your hands and knees, and then chin tuck and lift up. So you're coming into a neutral spine, and you're then strengthening the extensors against gravity. So keeping your neck and your neck strong, your thoracic spine nice and mobile, and then your lower back and your core nice and strong as well. So I think that's really important for...
That's what I still think is missing in the teaching at university for dental clinicians. We never got like, you need to do this every day, this exercise, and it will bring you to a safety health condition.
Oh, see if we can introduce it.
That will be nice. I know that in Denmark they are trying to introduce it in the university.
Oh, okay.
But I think it should be everywhere.
Yeah, I think the thing is that you've got so many professionals out there now that are kind of been long-standing and established, isn't there? So it's trying, I think, for the upcoming professionals, I think there's something that they need to try to look at. It's important, as you said, like it's going to be really important for them and you guys to maintain in work, to provide the service. And if you can prevent your back pain, which back pain is up there with one of the kind of leading causes of days off and time off work. So we want to try and make sure that we can prevent that where possible. And I think that simple things and keeping yourself active, really trying to promote some strength and core strength in there, as well as the mobility. The mobility is quite a good one for your thoracic spine, because what we tend to find is if the thoracics become quite stiff, then the rest of the mobility is driven from the lumbar spine, which makes that a little bit more susceptible then to kind of twinges. So if we can keep the lower back nice and strong and stable, and then the upper back quite mobile, that's where your range of motion comes from. And again, keeping that neck strong as well. So for you, I think that it's important one that we do introduce sort of some self-care.
Yeah, we should.
Yeah, I think so. That's for everyone.
It's
not
for
just
everyone.
Not just for you. It's
that's
for
the
everyone.
truth. That's the truth. I have my brother that does it because he has I don't know how it's to say it in English actually, but spondylitis and ankylositis.
Oh yeah, ankylosing spondylitis.
Ankylosing spondylitis. Okay. Yeah. So he has that. So I learn with him actually.
Yeah, totally.
Because every day he does this kind of exercises to keep it in a good
AS is
mobility.
Is really like mobility is key with AS, because it is, for those of you that don't know, ankylosing spondylitis is essentially a fusing of the vertebra.
Yeah.
So when it's an inflammatory condition that is driven by rheumatology essentially. So there's a genetic implement, actually. There is a genetic element to it, so that you can be positive for a specific gene. But yeah, ankylosing spondylitis is, because that's going to be starting to stiffen, it will stiffen as time goes on. Mobility and maintaining mobility is going to be essential, and keeping it nice and strong as well to take a little bit of pressure off the joint. So yeah, interestingly, I've had a patient with ankylosing spondylitis. It was a female. It's quite... she was pregnant. And when she became pregnant, all of her ankylosing spondylitis symptoms basically reduced. Because the ligamentous laxity through the pregnancy, it really helped with kind of her low back pain as a result of the ankylosing spondylitis. So she was one of these, was like, I want to be pregnant forever. But yeah, so mobility and maintaining some form of mobility with ankylosing spondylitis is a really important one, as well as obviously your typical therapeutic kind of rheumatology treatments, etc., etc. But yeah, there is some thought around nutrition with low-grade inflammatory conditions as well.
Yeah.
And I saw something this week which was looking at oral health and development of dementia. I don't know if you're familiar with that study.
Yeah, the bacteria that you find in the oral biofilm is the same thing that you find in the dementia in the brain.
Yeah, and it's because there's a direct kind of connective or connection between the the oral cavity and
It's the entry door for the general, the systemic health.
Yeah. And there's a lot of, I was speaking to Alex earlier, and he was saying that there's a lot of Leipzig, I think RB Leipzig, Red Bull Leipzig, have got a dentist on board, which they're saying is integral to the general health of the players. So, there's so much beyond the scope of what we would know as a standard practice. And there's a lot going on with nutrition at the minute, in the sense of inflammatory conditions that may be preventative, and looking at your gut bacteria and your gut biome as well. And that's one of the things that, if you have a poor nutrition, then theoretically it could be contributing to low-grade inflammatory responses in your system. I do have a tutor that was in university that swore that he cured his own AS by looking at his nutrition. I'm not so sure I buy that, but he probably helped manage his symptoms quite a bit by looking at his nutrition.
I think he helps. My brother helps a lot. I have friends and family with the Crohn disease, and I think that helps a lot.
Massive.
For sure. And joints, the most of the problems that we have in joints is inflammation. So if we can reduce inflammation through nutrition also, and by having a good oral hygiene, and by having prevention habits too, why not?
Exactly.
You should. And like you said, you have a dentist in the team to improve, to have the best performance. I think we need to start connecting a little bit more the different professions in the health sector.
I think so. I think that we're quite lucky with the rugby. With us, we've got basically one of everything. We've got a chiropractor, we've got multiple physios, we've got a sports therapist, we do have a dentist. The dentist is, looking at gum shield fittings, obviously the standard practice, but as well as the trauma, we have a doctor, we have multiple doctors. So we have a quite really, really good unit where everyone will come in with different ideas. And that's really important, that we appreciate every other professional input.
Yeah.
But I think the best way to combine that is by getting everyone's say and coming up with a plan, and almost like a multidisciplinary team.
True.
I think it's really important that the professions work together. I think that's key. But certainly, whether or not that's prevention or treatment or management, but I think that there's strength in numbers, and I think that the more communication between professions and professionals there are, the better outcome is for the patient, because that's the interest. The patient is the interest, irrelevant of ourselves. The patient is the interest, and we want to do best for that patient.
And you couldn't finish with a better statement than that one, Daniel. Daniel, thank you so much for being here with us. Thank you for treating me also before. It was really a pleasure to learn with you. I think the listeners will also enjoy it.
No, it's a pleasure. It's my pleasure, and thank you for having me. I think I've really enjoyed, actually. Really enjoyed.
Yeah, I think we could do it the second and third session, because the chat was really good.
Yeah, good.
Really good.
Good. I like to have a little read around the wider subjects as well, so it's quite nice. But thank you very much.
No, thank you. For the listeners, don't miss the other episodes, and subscribe our Smileys in the Air podcast in every platform that you are used to listen to our podcast. Can be on Spotify, Apple Podcasts, or even on YouTube. Say thank you, and see you soon.